morning. Today we're going to talk about childbirth. Specifically, we'll talk about the labor and birth processes, and then we'll talk about how to maximize the comfort for the laboring mom. There are what are called the 5 P's of labor. There is the passenger, which is the fetus or placenta. There's the passage, which is the pelvis and the birth canal. There are powers, which are the contractions that are helping to move the fetus and placenta through the canal. There is the psyche, which is the response of the woman to the labor, her psychological response. And there's position, which is the maternal postures and physical positions that help to facilitate labor. If you go to, if you look at the diagram here, you can see some of the positioning, and they'll talk about that, where the minus is above the ischial spine and the positive is the number of centimeters below the ischial spine. And just a little practice question here. The nurse has received report regarding her patient in labor. The woman's last vaginal examination was recorded as 3 centimeters, 30%, and -2. The nurse's interpretation of this assessment is that A, the cervix is effaced 3 centimeters, it is dilated 30%, and the presenting part is 2 centimeters above the ischial spines. B, the cervix is 3 centimeters dilated, it is effaced 30%, and the presenting part is 2 centimeters above the ischial spines. C, the cervix is effaced 3 centimeters, dilated 30%, presenting part is 2 centimeters below the ischial spines. And D, the cervix is dilated 3 centimeters, effaced 30%, and the presenting part is 2 centimeters below the ischial spines. The -2 is representative of the presenting part being above the ischial spine, so we can rule out C and D right away. And the correct answer is B. The correct description of the vaginal examination for this woman in labor is that the cervix is dilated 3 centimeters, it is effaced 30%, and the presenting part is 2 centimeters above the ischial spines. Birth is imminent when the presenting part is +4 or +5 centimeters below the spine. Effacement is the process by which the cervix prepares for delivery. After the baby has engaged in the pelvis, it gradually drops closer to the cervix. The cervix will gradually soften, shorten, and become thinner. You might hear phrases like ripens or cervical thinning, which refer to effacement. The fetal attitude is the relation of fetal body parts to one another. The horizontal lie is perpendicular to the mother. The longitudinal or vertical lie is when the long axes of the fetus and the mother are parallel. The normal attitude of the fetus is genuflexion. Vaginal birth cannot occur if the fetus stays in a transverse lie. There are 4 stages of labor. The first stage of labor is considered to last from the onset of regular uterine contractions to full dilatation of the cervix. The first stage is much longer than the second and third stages. In a first-time pregnancy, the first stage of labor can take up to 20 hours. The second stage of labor lasts from the time the cervix is fully dilated to the birth of the fetus. The average length is 20 minutes for a multiparous woman and 50 minutes for a nulliparous woman. So first time, the second, or for a woman having after her multiple births, the second stage can last as little as 20 minutes. And typically on a first go around, it can be 50 minutes to an hour. The third stage of labor is from the birth of the fetus until the placenta delivers, and this can take as little as 3 minutes or as long as an hour. The fourth stage of labor, recovery, lasts about 2 hours after the delivery of the placenta. Understand, in a first-time pregnancy, descent is usually slow but steady, and in subsequent pregnancies, descent can become more rapid, resulting in a shorter duration of labor. Another question. While providing care to a patient in active labor, the nurse should instruct the woman that A, the supine position commonly used in the United States increases blood flow, B, the all fours position on her hands and knees is hard on her back. C, frequent changes in position will help relieve her fatigue and increase her comfort. Or D, in a sitting or squatting position, her abdominal muscles will have to work harder. The correct answer here is C. Frequent position changes relieve fatigue, increase comfort, and improve circulation. Blood flow can be compromised in the supine position. Any upright position benefits cardiac output. The all fours position is used to relieve backache in certain situations. In a sitting or squatting position, the abdominal muscles actually work in greater harmony with the uterine contractions. True labor contractions bring about cervical changes in cervical effacement and dilation, and with false labor, the contractions are irregular with little or no cervical changes. The conclusive distinction between true and false labor is that contractions of true labor cause progressive change in the cervix. Bloody show can occur before true labor. Fetal descent can occur before true labor. As the cervix begins to soften, dilate, and efface, expulsion of the mucus plug that sealed the cervix during pregnancy occurs. Braxton Hicks are regular contractions that occur after the 3rd month of pregnancy. They may be mistaken for regular labor, but unlike true labor, the contractions do not grow consistently longer, stronger, and closer together, and the cervix is not dilated. Some patients present with preterm contractions, but only those who demonstrate changes in the cervix are diagnosed with preterm labor. Another question? A prima gravida at 39 weeks of gestation is observed for 2 hours in the intrapartum unit. The fetal heart rate has been normal. Contractions are 5 to 9 minutes apart, 20 to 30 seconds in duration, and of mild intensity. Cervical dilation is 1 to 2 centimeters and uneffaced, which means it's unchanged from admission. Membranes are intact. The nurse should expect the woman to be A, admitted and prepared for a cesarean birth, B, admitted for extended observation, C, discharged home with a sedative, or D, discharged home to await the onset of true labor. The answer is D. This situation describes a woman with normal assessments who is probably in false labor and will probably not deliver rapidly once true labor begins. These are all indications of false labor without fetal distress. There is no indication that further assessment or cesarean birth is indicated. The patient will likely be discharged. However, there is no indication that a sedative is needed. Engagement occurs when the greatest diameter of the fetal head passes through the pelvic inlet. Engagement can occur late in pregnancy or early in labor. Descent is the movement of the fetus through the birth canal during the 1st and 2nd stages of labor. Flexion is when the chin of the fetus moves toward the fetal chest. Flexion occurs when the descending head meets resistance from maternal tissues. This movement results in the smallest fetal diameter to the maternal pelvic dimensions. It typically occurs early in labor. Internal rotation is the movement, the rotation of the fetal head with the long axis of the maternal pelvis. It occurs mainly during the 2nd stage of labor. Extension is the movement facilitated by resistance of the pelvic floor, causing the presenting part to pivot beneath the pubic symphysis and the head to be delivered. This occurs during the 2nd stage of labor. External rotation is when the sagittal suture moves to the transverse diameter and the shoulders align in the antero-posterior diameter. The sagittal suture maintains alignment with the fetal trunk as the trunk navigates through the pelvis. Expulsion is the movement that occurs when the shoulders and the remainder of the body are delivered. We'll move on to maximizing comfort for the laboring woman. We first need to kind of understand pain during labor and birth. Pain during childbirth. Number 1, encourage expectant parents to attend childbirth preparation class. This is most important because preparation increases a woman's confidence and helps with her ability to cope with the labor and the birth. Each woman's pain during childbirth is unique and is influenced by a variety of physiologic, psychosocial, and environmental factors. Review your cultural considerations in your maternal text. Hispanic and Native American women tend to be quite stoic during labor and delivery, but as labor progresses, they may be ready for medications in the later stages. African American women may express pain openly. Use of medications for pain is more likely to vary with the individual. Support makes a significant difference in the pain of a woman during labor and birth. The nurse has an obligation to provide physical, emotional, and psychosocial care and support to the laboring woman. Pain management conversations with pregnant women typically start during the third trimester as plans for delivery are being made. Informed consent for anesthesia is required. Assessing pain in labor and birth. The assessment of the woman, her fetus, and her labor is a joint effort of the nurse and the primary health care providers who consult with the woman about their findings and recommendations. Understand this, the needs of each woman are different, and many factors must be considered before a decision is made whether pharmacological methods, non-pharmacologic methods, or a combination of the two will be used to manage labor pain. Some of the signs of pain in labor and birth include the respiratory patterns, increased rate of breathing, increased anxiety, crying or groaning, gesturing, and excessive muscular excitability. Endorphin levels in pregnant women tend to increase, and these are the levels that give us that feel-good feeling. The higher the endorphin levels available to the laboring woman, the more likely she is to tolerate pain and have reduced anxiety and irritability. The visual analog scale is a means of adding the woman's assessment of her pain to the nurse's observations. Anxiety and pain reinforce each other in a negative cycle. Mild anxiety is normal for a woman in labor and likely needs no special treatment other than standard reassurances. But anxiety, as it increases, also increases muscle tension and ultimately can build to the point that the progress of labor is slowed. Unfortunately, an anxious, painful first labor is likely to carry over through expectations and memories into an anxious and painful experience in the second pregnancy. Studies have shown that with a support person, for example, a family member, friend, or a professional such as a doula or nurse, the patient experiences a decrease in anxiety and has a feeling of being more in control. This in turn results in a decrease in interventions, a significantly lower level of pain, and an enhanced overall maternal satisfaction. Let's take a look at some of the types of pain. As labor progresses, the woman often experiences referred pain. This occurs when pain that originates in the uterus radiates to the abdominal wall, the lumbosacral area of the back, the gluteal area, and the thighs. The woman usually has pain only during a contraction and is free from pain between the contractions. Visceral pain is predominant during the first stage of labor. This is pain that originates from the cervical changes, distinction of the lower uterine segment, and uterine ischemia. Visceral pain is located over the lower portion of the abdomen. Somatic pain is described as intense, sharp, burning, and well localized. This results from stretching of the perineal tissues and the pelvic floor. This occurs during the second stage of labor. Pain experienced during the third stage of labor or afterward during the early postpartum period is uterine. This pain is very similar to that experienced in the first stage of labor. Non-pharmacologic pain management techniques, there are quite a variety. A lot of these are learned in classes preparing the parents for labor and delivery. So you really want to encourage them to take advantage of the classes that are available to help them prepare. Some of the things that they will learn in their education is counter pressure. Counter pressure is a steady pressure that's applied by a support person to the sacral area in the lower back with the fist or heel of the hand. This technique can help women cope with the sensations of internal pressure and pain in the lower back. Upright positions in labor usually result in improved comfort and less pain. Moving freely to find more comfortable positions is important for reducing pain and muscle tension. First stage techniques, breathing techniques, promote relaxation of the abdominal muscles, thereby increasing the size of the abdominal cavity. Instruction in simple breathing and relaxation techniques early in labor is possible and effective. Controlled breathing techniques are most difficult in the transition phase at the end of the first stage of labor when the cervix is dilated 8 to 10 centimeters. Patterned paced breathing can sometimes lead to hyperventilation. You know that. Be careful with that. We don't want to lead to hyperventilation. Non-pharmacologic methods may be the only option for the woman in the advanced labor. There may not be time for an epidural or spinal anesthesia. Imagery is a technique of visualizing relaxing images. Dissociation helps the woman learn to relax all muscles except those that are working. Effleurage is self-massage. Distraction can be used in the early latent phase by having the woman engage in another activity. Some other methods include music, aromatherapy, warm bath or shower, or transcutaneous electrical nerve stimulation, or TENS for short. Pharmacological pain management. Meperidine or Demerol is the most commonly used opioid agonist analgesic for women in labor throughout the world. Because tachycardia is a possible adverse reaction, meperidine is used cautiously in women with cardiac disease. The use of meperidine in labor is controversial because of effects on the neonate. An opioid antagonist such as naloxone or Narcan can be given to the newborn as one part of the treatment for neonatal narcosis, which is a state of central nervous system depression in the newborn produced by an opioid. Naloxone can promptly reverse CNS depressant effects such as respiratory depression. An opioid antagonist is especially valuable if labor is more rapid than expected and birth is anticipated when the opioid is at its peak effect. Understand this, an infant delivered within 1 to 4 hours of maternal analgesic administration is at risk for respiratory depression from the sedative effects of the narcotic. Sedatives can be used to reduce the nausea and vomiting that often accompany opioid use. Meperidine is notorious for causing nausea and vomiting. In addition, some drugs, atoractics, are used to reduce stress or tension without reducing mental clarity. Some atoractics, which are drugs that are used to reduce stress or tension without reducing mental clarity or any anxiety, reduce anxiety and apprehension while potentiating the opioid analgesic effects. You will hear a lot of laboring moms talk about the epidural, and if they've made plans for this, it's a wonderful thing. A lot of it depends on where they are at in the laboring process, however, and we'll talk about that. An epidural provides anesthesia for the uterus, perineum, and legs. A spinal block provides anesthesia for the uterus, perineum, and down the legs. It is easy to confuse a spinal block and spinal epidural because they are both injections into the spinal area. For a spinal block, narcotics or anesthetic is injected once with a needle. For a spinal epidural, a catheter is placed in the epidural space to allow continuous anesthesia, which allows them to monitor the ebb and flow of that anesthesia as well. The most important nursing intervention for a woman who has received an epidural block is to monitor the maternal blood pressure frequently for signs of hypotension. IV fluids are increased for a woman receiving an epidural to prevent hypotension. The nurse observes for fetal bradycardia. The nurse also monitors for signs of maternal tachycardia secondary to hypotension. In your text, look at the emergency treatment box for maternal hypotension with decreased placental perfusion. This is an important box to pay attention to. A high incidence of afterbirth headache is seen with spinal blocks. Headaches may be prevented or mitigated to some degree by a number of methods, such as the blood patch, where blood is injected into the epidural space in the area of the puncture, forming a seal of the hole to stop the leakage of cerebral spinal fluid. Spinal blocks may be used for vaginal births, but the woman must be assisted through labor. Epidural blocks limit the woman's ability to move freely. Combined use of spinal and epidural blocks is becoming increasingly popular. And we have a little question. A woman is in the second stage of labor and has a spinal block in place for pain management. The nurse obtains the woman's blood pressure and notes that it is 20% lower than the baseline level. Which action should the nurse take? A. Encourage her to empty her bladder. B. Decrease her intravenous rate to keep vein open rate. C. Turn the woman to the left lateral position or place a pillow under her hip. D. No action is necessary since a decrease in the woman's blood pressure is expected. The correct answer here is C. Turn the woman to the left lateral position or place a pillow under her hip. This is going to help improve placental perfusion, and you would not want to decrease the IV fluids. There's a potential that it may have to increase. Nerve block, analgesia, and anesthesia. Most local agents used for nerve blocks are related chemically to cocaine and end in the suffix "-cane". Common agents include lidocaine and chloroprocaine. Injections can be repeated to prolong the anesthesia. A pudendal nerve block relieves pain in the vagina, vulva, and perineum, but not the pain from uterine contractions, and it lessens or shuts down the bearing down reflex. A pudendal block anesthetizes the lower vagina and perineum to provide anesthesia for an episiotomy and use of low forceps if needed. Final question. When monitoring a woman in labor who has just received spinal analgesia, the nurse should report which assessment findings to the healthcare provider. Select all that apply. A maternal blood pressure of 108/79, a maternal heart rate of 98, respiratory rate of 14 breaths per minute, fetal heart rate of 100 beats per minute, minimal variability on a fetal heart monitor. Your answers are going to be D and E. After induction of the anesthetic, maternal blood pressure, pulse, respirations, and fetal heart rate and pattern must be checked and documented every 5 to 10 minutes. If signs of serious maternal hypotension, the systolic blood pressure drops to 100 or less, or the blood pressure falls 20% or more below baseline, or fetal distress such as bradycardia, minimal or absent variability, late decelerations, if any of these develop, emergency care must be given. Read your chapters 13 to 14 in maternal child nursing care, and in your ATI text, chapters 11 to 12.